Welcome to the Prescription for Admission podcast, where we talk about hospitals and hospital-based care, who you can expect to meet, and what you may experience during your time in the hospital, both as a patient and also as a healthcare provider working in a hospital. My name is Dr. Monique Nugent. I am a practicing hospitalist and also the author of Prescription for Admission, the book, where I talk about many of the same topics. Thank you for joining me and enjoy the show. Welcome back to another episode of the Prescription for Admission podcast, where we talk about hospitals, all things hospitals. And for that, I am your host, Dr. Monique Nugent. I am a practicing hospitalist and also the author of Prescription for Admission, the book, which is really kind of an intro to a lot of these topics. But on the podcast, I get the opportunity to delve in depth into a lot of different topics with great people who have so much more information to share with us. And today, our guest is Dr. Lees. Dr. Lees, thank you so much for being here.
Oh, thank you for having me. It's good to be here.
Dr. John Lees, with over 2 decades of experience in healthcare technology, has a distinguished career marked in innovation and leadership. From co-founding Trella Health to his current business, Copay Technologies, to scaling businesses and enhancing operational efficiencies for large organizations, he's consistently delivered value in every role. Holding a PhD in physics and a specialization in computational physics, Dr. Lees brings a unique analytical perspective to solving the complex challenges of healthcare. His career has spanned strategies, management consulting, executive leadership, and entrepreneurship, all driven by a commitment to make healthcare more transparent, efficient, and patient-focused. John, thank you so much for being here and talking about this important topic. We're going to be speaking about transparency and pricing in hospital care. And so, again, thanks for being here.
Oh, Monique, thanks very much for having me. I'm glad to be here.
Before we dive into our topic, I always like to talk to people about their journey in their career and how they got to this place in their career, because we have students who listen, and I love that you have a PhD, because every other doctor that I have interviewed is a physician, right? But there's so many roles in healthcare and how we improve healthcare, and so many ways that people can use their skills. And you're exactly what it said in your bio, your analytical way of thinking of things brings a lot of benefit to healthcare. How did you go from physics to healthcare?
That's a great question. And I'll try to keep it succinct because I'm living proof that you can start anywhere and then go anywhere.
Yeah.
So when I entered my doctoral program, I thought for sure I was on the path towards academic physics. I was going to go be a research physicist or a professor somewhere. And I got to the point where I was working on my dissertation 6 days a week, 18 hours a day, and I really just wanted to do just about anything else at that point.
I hear a lot of PhD candidates say the same thing.
and so literally I was working on my dissertation, and a friend and former colleague who had graduated and was working in management consulting reached out to me, and he said he and his team had been working on this, trying to get the optimal call algorithm for routing calls for the largest call center in the United States. 26 call centers, 40 million calls a year. And every time they worked on it, he and his whole team, it blew up. And so with that mindset that I was going to do something, anything else, I said, all right, I'm going to go play with it. And so over my lunch break, I worked on it. And 40 minutes later, I sent him the answer. And almost like my friend had it rehearsed, he said, welcome to the high impact, high paced world of management consulting. And I was sold.
Yeah.
And I originally got hired to be a brain in the closet because, they think, a PhD in physics can't actually talk to people. So
not true.
Yeah, hopefully not true. Within 2 weeks, in management consulting, I'm talking to the commissioner of the IRS.
Wow.
And before I departed in my entree into healthcare, I was leading the organizational redesign of the CDC. And
Wow.
so that's quite a jump into healthcare with both feet type
Both,
of issue. And
yeah.
so ever since then, I've been in executive roles, have a startup that's now, I guess, a medium-sized company, and now starting this new venture of copay technologies.
Yeah. And so I love that you said you're just like jumping into really what is the group project of healthcare in this country, right? Like everybody has something to bring to the table. And I can tell you, if someone asked me to make some kind of analytical algorithm for any call center, I would no, it would not go well. And getting that answer in 40 minutes, it just shows that like there's so many ways to use your gifts, your natural talents for helping everybody in healthcare. And like if you're starting off reorganizing the CDC, that's hey, kudos to you. Thank you so much for doing that great work because that's public health. That's looking out for all of us. So thanks.
Yeah,
That's
but
amazing.
it's not an easy ride, though. If you start out with the concept that every problem has a solution, maybe not a perfect solution, but you can make things better, then you can start to make progress. And I
Yeah.
tell you, I make it sound a little glib about the CDC, but I went into that first meeting with the like 30 top leaders of the CDC and telling them plans about our approach and how we were going to look at things. Not that we had the answer, but we were going to engage them on the answer.
Yeah.
And the moment after my 5-minute introduction, I stopped talking. A gentleman stood up with great authority and great gravitas. And he said, if you enact this plan, he said, and I am the leader of all of the level 4 labs in the country. I have Ebola, smallpox. I manage those specimens. Wow. If you enact this plan, you will be endangering the health of the entire United States of America. So
That's
how that
heavy.
project started. Yeah. So what's the first thing I do? The moment that we finish, I go and talk to him and say, well, you need to be part of the core team.
Yeah.
And help us figure this out together so that we don't endanger the health of every person, that we make things better for everybody. And
Yeah.
you bring your biggest detractors close in and work together on the solution.
Yeah, when I've worked on projects and changing things within a healthcare system, within a hospital, there's always people who have done it away. This is the way we do things. This is the way it works. And I think it's hard sometimes to reimagine that it can work differently. And there's a good way that was the way you were doing it. There's a good reason. And now maybe there's a good reason why we need to rethink that. And I think that's really great. Like you said, go to people when you're doing these big projects, find your stakeholders, make them, buy in, and you find out what they need, what they mean. I'm sure when he said like, you will give everyone Ebola, what he meant, what he meant was like, I am concerned about how, these labs will be run. Translate.
He said it great a couple minutes ago. Everybody brings something to the table, right? He could have entrenched, I could have entrenched, and then we could have gone nowhere. But if we, can meet and then discuss our differences of opinion and work together with a common set of facts and information, then we can progress forward.
That's awesome. So now your company focuses on transparency in healthcare pricing.
That's correct. Yeah.
So this is exciting because we haven't had pricing conversations on prescription for admission. And I think there's this idea that when you go into the hospital, it's like weekend calories. It doesn't count, that like whatever happens here, insurance is going to cover. Whatever happens here will somehow work its way out. But cost is actually, for me as an inpatient physician, often top of mind because I want to make sure people can continue to access their healthcare. And if I do what we colloquially call in medicine a wallet biopsy, meaning we just go ahead and just give you a whole bunch of tests, a whole bunch of medicines that maybe aren't going to be covered, then we can run into problems because you may not financially be able to continue to access this care or continue to get the things that you need to get further diagnosis, right? So in economics, there's this idea that an informed consumer makes an informed choice because I have information.
Right.
Right. So so in economics, there's this whole idea that like The reason we do things is because we have all of the information and we have synthesized that information to say, this is the best decision for me, be it financially, even in behavioral economics, right? I do this thing because it is going to work out for me, because I have all of this information. But in healthcare, getting all that information is not easy. Like, what information do we have really when we think about healthcare pricing?
Yeah, that's a great question. And unfortunately, the answer is not much. And in the first Trump administration, there was an order for hospitals had to publish their pricing. It came with mixed results. And now in the second administration, they came out with a second, more stronger order about publishing pricing. Mm-hmm. But it's still deliberately opaque in lots of ways. And not to say it's 100% that way, but you have, I live just outside of the New York City area, and you have major hospitals, world-renowned hospitals in Manhattan, who refuse to publish pricing, and others who put it in such a way that there's no way that the consumer can absorb it and make any sort of useful decisions out of it. Like deliberately, they'll say, this is a machine-readable only file. So technically, they've made their pricing available, but it can't be used.
Wait a minute. When you say they say like this is a machine-only readable file, like they're sending people in their emails, or is it on their website?
No, it's like available on their website.
Available on their website. And so what machine are we supposed to use?
They could use, they would have to go download a program that would then, parse out the information. And because I'm in that industry, I went to that effort to do so. And it still wasn't very readable. And I still found mistakes in it, even after all of that effort. And this is, without naming names, is the most profitable hospital in all of New Jersey.
Wow. So when people think about hospital pricing, right, the thing that we hear is like a $50 Tylenol, right? Like, why does my Tylenol cost $50 in the hospital, but I can get a, thing of $500 for $7.99 at CVS?
Right. Well, as you get your bill from the hospital, you never see anything listed on there as electricity or water and sewer, right? So these are all costs that are fixed in the hospital, but they can't charge for it, right? So they get built into services and products and so forth. So hospitals maintain what's called a charge master, the pricing of every item, and then they figure out a multiple. Is it 2x? Is it 5x? Is it 8x of that to maintain, and they adjust their revenue based on that multiple, based on their charge master. So that's how you get the proverbial $50 Tylenol, because you get wrapped in every other cost that they can't charge for into that product. And in typically inpatient care, as you know much more than I do, there are a lot of level of services associated with that. You have, multiple nurses on call, you have residents on call. It's much different than an outpatient level of care that is maintained for probably more acute level patient that needs monitoring, needs a bed, and needs that hospital center of attention.
Yeah, so that's something that I hear often, that, well, an MRI at X place outpatient is, I'm making up numbers. Please, no one go and try to get, but I'll make up a number. Like, it's like $900. But the MRI in the hospital is $3,000, right? Or when I say to patients, this might be care that is best sought in an outpatient setting, right? I think you're safe to get this echocardiogram in an outpatient setting. I think you're safe to get that MRI in an outpatient setting and have someone else follow up on it. That's really what I'm saying some of the times, is that like, this is, yes, you're in the hospital, and now we've seen you, we've come up with a plan, and you are safe. This piece of information isn't going to change a lot of what I'm going to do now, and it's not going to make you any less safe to get this piece of information a week from now, 2 weeks from now, because those things can be, like you said, the outpatient setting versus the inpatient setting, the pricing can be quite different for exactly the reasons you were talking about.
Oh, for sure. And you can see that. So my COO a year ago had to get rotator cuff surgery. So he's out west in the greater Salt Lake City area where Intermountain is the primary like IDN of source. So,
Okay.
and he was just beginning to get involved in copay. And so he said, well, let's see if Intermountain publishes their pricing. And they actually have a really good system. So he said, based on his insurance, based on his needs, based on his surgeon,
Okay.
he looked at relative care. So again, same insurance, same provider network, but different facilities. There was one facility it was going to cost him $12,000, and another facility over $20,000
Wow.
in the same network.
In the same network.
Insurance, same.
So
same-
was one an outpatient surgical center?
And that's
Was that the
exactly it.
cheaper one? Right. So I also wonder, like, is it also not just the electricity, not just sewage, price of the little paper cup, all these things roll in? Do we also see higher hospital costs because hospitals have to roll in the cost of care that they are not paid for?
Oh, for sure. For sure. Here in New Jersey, there's actually a pretty good charity care program where, and a lot of people don't know about it, but if you can't pay your bills, charity care will meet you a lot of the way. But that's not the way it is in a lot of the country.
Right.
And so to manage those costs that hospitals, when they're covering indigent care and so forth, it's so population dense here, we can go 20 miles south and you have an entirely different population of care and providers and facilities where 80% of their patients that they admit are coming through the ER. And that's very expensive, and they are most likely not going to get compensated for that. So they end up having to build that into those other costs.
Does the hospital, being a non-for-profit hospital versus a privately or for-profit hospital, does that make a difference in pricing as well? Because I know, like in Texas specifically, when I've done this type of exercise, there's huge swings in pricing, and people just say offhand, well, that's a private hospital. Well, that's non-for-profit, so of course it's good. Does that make a difference?
It definitely can. There are more regulations on the not-for-profit, so they are limited in what they can do. The average nonprofit hospital runs a negative 3% margin, whereas the average for-profit hospital runs a 4 to 5% profit margin. So -3 versus 4 to 5%. So there's a pretty good swing there, and that isn't just because they're charging more, but they're also incented to streamline more than the nonprofit. So there's a bit of both factors going into play there.
So when people come into the hospital through the emergency department, right, they're not that consumer that gets to make decisions with information, right? You show up and you're like, I'm here in the emergency department, so I'm not going to get a lot of choice, right? I need to be here. Versus somebody who needs rotator cuff surgery gets to make those decisions. I've gone through this exercise myself. One of my children needed a procedure, and I was like, I am going to make the best financial decision. But I found that it wasn't just the hospital pricing, right? You're also talking about paying for the anesthesiologist. I didn't have any information on that. They were just like, oh, this surgery will cost an average of blah, blah, blah. And I was like, how much is anesthesia? And they were like, this surgery will cost, okay, but like, right. So the anesthesiologist was a different group, and you want anesthesia when you're doing these things. So you're not going to choose to not do that, right? As the consumer making the choice. I chose my surgeon or child surgeon based off of what we know clinically of them. That wasn't a financial decision at all, because we're like, okay, we're going to make a strong clinical decision. But again, I had no idea about the surgeon's pricing, but you also want a surgeon for surgery. So it's not like you're going to say no to that. So in addition to the hospital bill, sometimes there's other bills that will pop up that people may not think about or know about. And so when I hear people say like, oh, well, the surgeon has said they're not going to charge for that, the surgeon's fee might not be as much as you think. the surgeon's fee might actually, in comparison to the hospital's fee, be quite small in comparison to the hospital's fee, right? Is there a way for people to find out those type of practitioner fees?
Oh, for sure. But it's difficult, right? So there's the No Surprises Act. And so, but there are ways, quote unquote, around that. If doctor orders lab work, they don't have to tell you that it's out of network. All you have to do is sign and say that you're going to accept that network, and then it goes out of network.
Oh, the lab work. Yeah.
The lab work or the other ancillary charges. And so one of the things that we do is when we look at a patient's bill in your copay, we combine all the bills associated with that patient and bring it together. But it's not easy to do for the individual consumer to understand that. They would have to be very savvy, or really the patient. But we like to think of, if you're a patient, you're also a consumer, but to look at all these various fees. Some facilities will provide estimates, but again, they're estimates, just as what we're providing is an estimate. But it's arcane at best and opaque at worst.
So there's lots of barriers to finding out what these prices are. Like you said, the read-only files or the machine read-only files, that's a new one on me. But just finding the pricing. And then you said, the different practices and lab groups, even labs, is your lab out of network? These are not things that people are thinking about when they come into the hospital. And oftentimes, because your doctor's doing things like ordering labs, I don't know if the doctor even knows if the lab is out of network or in network, right? Because they may not be aware of your insurance. If you're working for a larger institution, you have as the individual physician, you have no say in the contract for the lab. I have no idea who writes the contracts for the labs of any of the hospitals that I work with, right? And so even if you're in an outpatient setting, you may still not know who writes any contracts for. So we may not, as your physician, know anything about where these things go.
Right.
And so getting all
whether you're the patient or the physician, we've all been more or less trained or inured to what some of the costs are, because that's the way it is and that's the way it's always been. But I think the more that we can sort of capitalize and make people aware, then we can make informed decisions. And back to the economic comment you made several minutes ago, Monique, not only does information allow consumers to make good choices, but when consumers make good choices, there's also implications to the market.
Right?
Because once you go to, let's say you find that lab that does better work, faster work for less pricing, they're going to get more work as long as people have knowledge that that's the case, right?
Right.
And then the labs that aren't as good will see that they're suffering, and they'll either step up and be better, faster, cheaper, or they'll continue to lose market share until they're no longer viable. And so that's how really capitalism works. And not that capitalism necessarily works in all settings, but if we brought a little bit more into healthcare, I think everyone would benefit.
But it sounds like we can't put market pressures because we don't have information to participate in the market in that informed way. I have never once thought about the lab that never once. So I think it's a lot for patients and their family members, caretakers to think about, because you're right. It's so ingrained in us as American patients that you just do these things. You go to Quest Lab because they told you to go to Quest Lab. People don't,
Right.
I don't know if people know that there's another option or ask to know, right? Oh, actually, I know of this lab. Can I go there instead? And then you talked about information. How does that information get back to, let's say you go to Dr. Lee's lab, and it's great, it's fast, it's efficient, you get all your lab stuff and it's cheaper. But now how do we get that information back to me? Because information isn't shared easily between healthcare institutions. It's the system is
That's right.
so siloed that it continues to create what's happening, right? So I have a friend who is an engineer, and he says all the time, every system is perfectly created to get the results that it gets, right? It doesn't mean that that's the result you want,
Right.
but but the reason that it is the way it is because of the system and how we have created the system. And getting more information and being able to participate on more equal footing, I think would help us to put some pressure on the system. So how do you and your company help people to get that information?
Yeah, that's a great question. So the way that we are starting, and we break it into various phases, is we're first looking to empower the patients. So we're hoping that patients will supply their information, their results, and we keep everything anonymous. We don't sell personal data. In fact, we don't even keep names or any sort of PHI related to people if they are willing to submit their bills to us.
Okay.
And so we capture that and aggregate it and then provide it back to the patients. So in your examples of anesthesiology or lab work, we capture that data. And so that we didn't start with zeros, we've also licensed a bunch of claims data so that we have a large data set. And while we've launched just currently in the New York City area, we have 26 million claims that we've brought in, that we've analyzed and put into our data. So if you search, you're going to get some level of result for that, and it will have, based on your location, you'll have for your insurance, your expected out of pocket or whichever service you're looking for.
So like in the case of my child, if I came to you and I said, hey, we're looking for a pediatric surgeon, B, a place to have surgery, pediatric surgery, C, an anesthesiologist, and D, aftercare. But I don't have these bills yet. Because you have had all these claims, you would be able to tell me for your insurance, these are the players and how much they would cost.
Right. And we have examples already. We're just live since July, so we're pretty nascent still. We have examples where people have searched for lower back surgery, and they found that if they just traveled 2 miles more, their out of pocket was going to be $3,500 less.
Wow. So you also do the insurance out of pocket, like total cost, because that is the other side of it that like people kind of give up on.
Right.
People say like, well, I have to pay X amount out of pocket every year, so it doesn't particularly matter. I'm stuck paying $4,000 for the year at minimum.
Right.
I've heard people think, oh, it doesn't matter. Like, whatever they bill, they're still going to put it back on me. So,
Exactly.
So that's awesome.
That's just our beginning, right? So, just like yourself, Monique, physicians, we want to put patients first. So patients are first in what we're doing. The second is we want to provide this data to the providers, the physicians, the facilities, and aggregate that up so that they can see, here's our care of services down the street. This is their care. These are their reimbursements. And so we're then providing, across that middle layer. And then eventually in what we call stage 3 is then provided to the payers, the insurance companies. How is Aetna performing versus Blue Cross Blue Shield versus Horizon or versus UHC, and gather that data and provide it. So in essence, once we get through all of those stages, we want to have price care transparency through the entire healthcare vertical. And we're hoping in that instance, then it provides downward pressure on costs, but then also provides upward pressure on quality, because we're going to be gathering the quality information as well. And so there are 70 million Americans or more that are on high deductible healthcare plans who are highly incented to shop for care.
Yeah.
And so we want everyone to get the best care, but there are always, costs need to be mined. And if you have two equal facilities in terms of quality of care, you're probably going to choose the one that's going to cost you less, especially if you're paying significantly out of pocket. So maybe you'll travel a couple extra miles for that care, but only if you're armed with that information.
Yeah. I think in healthcare, we're always chasing that trifecta of lower costs, better outcomes, more efficiency. And I will admit that as someone who has worked in hospitals, sometimes I'm like, I don't know. I don't know how much more we can do, but we'll never find out if we're not continuing to try and if we're not continuing to participate. And giving everyone information is, I think, one of the biggest steps forward. There are going to be people, for our listeners, are going to be people who end up in the hospital to see me who don't have a choice.
Right.
But that hospital stay will end and there will be things to follow up on. There will be next steps. And how do you think about continuing to access those next steps in a way that is affordable and sustainable?
Right.
You know, and there are also, as much as people will show up in the hospital to see me, there are a lot of people who will show up in their primary care doctor's office who get a choice, right? Who will get a choice to say, hey, you need to be referred to a cardiologist. You need to be referred to an orthopedist. And how do you make those choices is also going to be really determined by the information you have.
Exactly.
Yeah.
Went back in my telehealth in our early days, we did analysis, and only 60% roughly of facilities gave patients discharge papers. But we found those that received discharge papers are 80% less likely to get readmitted.
When was that? Tell me that's changed, because I'm all about discharge papers.
That was circa like 2018, so it was a few years ago.
Yeah.
So, but I remember that was critical information finding that we had once we got access to nationwide billing claims.
Yeah. And the reason why...
Once they have those discharge papers, they're going to have follow-ups, right? And so then they have that time to look for where's the best and least expensive care that I can receive.
And I think that's very telling, because I can tell you the reason why they were probably not admitted as much is because they had information in general, right? They had their lists of medications that they needed to take, the lists of follow-ups that they had. Like they had information. Information in healthcare is safety, and information in pricing, right, is going to give you the ability to be an informed consumer that makes the best choices for you.
Right.
So this has been an awesome, awesome conversation. Like I said, we've never talked money before on, I think we've spoken about money like roundabout, but it's a big, clearly in American healthcare, right? How many bankruptcies do we have that are driven from healthcare costs?
And not dischargeable through bankruptcy either.
Yeah. You know, at least in my heart, I don't feel like anybody should ever be denied healthcare because they can't afford it, right?
I would agree.
And so if this is a system that we as Americans have decided we're going to participate in, then we've got to have that information. We've got to have that information. And I think the No Surprise Billing Act is an attempt to try that, because there's like nothing worse than coming home afterwards and you're like, what? I had no idea that I saw this person. I had no idea that lab was out of network. I had no idea, So I think that was an attempt. But if people are not, and institutions are not participating, and then it's also, like you said, that's a lot of information for one person to understand how to synthesize.
Yeah. The very good thing about the No Surprises Act is like it's really meant to be covering that emergent level of care. Mm-hmm. However, ambulances aren't covered to that.
I was going to ask you that if ambulances were covered, because I wanted you to say no.
And so that, I know at least in the city, that's a $30,000 cab ride.
It is.
And
yeah.
That you could be potentially fully responsible for. But even for the non-emergent, once you get to the non-emergent care, then the coverage is a lot looser there. If the physician, or again, coming back to that lab work, physician orders out-of-network lab work, and you sign a paper, then you're responsible for that. And it's very easy for patients to kind of, while they're, of course, first and foremost, they get lost in that financial aspect of the hospital system.
But nobody even knows that they should know to know. Like,
right.
That's the thing. Like, I don't.
Yeah, there's lots of barriers to that knowledge. Again, circling back around, because that's the way it's always been.
Exactly. Right? And that's how we started the conversation. Maybe there were good reasons for the way it was, but now we've got to change it. We've got to give people information so that they can participate in their healthcare in a sustainable, affordable way. And Dr. Lees and his company are doing so. And this is great. This is great because there's so much going on in a hospital, say. Even if you signed up to be there, right? Your friend who went for rotator cuff surgery, like, even though he was excited to get his rotator cuff fixed, there's still a lot going on in the day. He's anxious, he's hungry, there's pain afterward. There's all this stuff going on. And then you're expected to synthesize information as to, like, did I sign something that says that I'm going to be seeing an out of network fill in the blank? That's that's very unfair.
Yeah, and if he wasn't involved in this project, your copay and liberally on healthcare pricing transparency, he never ever would have thought to even look.
Yeah. Like I said, with me, we tried. I tried. I was like, I am going to do this. And my decisions were driven mostly clinically, and then also kind of gave up after a while. It was like I made what I felt were the best clinical decisions, finding a clinically strong surgeon who we were comfortable with, and then, like, okay, also, and what was my insurance going to cover? What's in network for children's hospitals, and children's hospitals, they're not everywhere, right? So there's like X number of children's hospitals. So I'm going to go to the one that, again, clinically I feel more comfortable with. And then, it was just like, it got to a point where I was like, well, we got to pay it anyway. So I did. We really gave up. It's like, what am I going to do? Pick an anesthesiologist that no, I'm going to go with the on-call person. I don't know. Right. What their bill is going to be. And I want anesthesia for this. It wasn't, it wasn't like, I didn't feel bullied, but I will admit that what started as like a project that I felt I wanted to be empowered ended with me feeling like, what am I going to do about it?
Right. And you're more well suited than most, right? But still, you were a little bit of lost in the woods.
Yeah. It was just like, well, what am I going to do? I can't do anything about that. So I guess we just go with what's happening.
Well, I hope she's doing well today.
So she's great. She's great. But it's just like, yeah, Dr. Lees and Copay are out here trying to help you not feel like I just have to go with it. So this is great work. And I encourage people, do your best to try and find out pricing. Ask questions, right?
That's right.
Not just of your healthcare provider, because I hate to say that a lot of the times we have no idea. Like, I have no idea what a CAT scan at my facility costs for you being inpatient versus you coming as an outpatient. I have no idea. So the people you need to ask will be your insurer, will be the facility themselves, and will be companies that are working on this, like Copay Technologies.
Yeah, at the end of the day, it's incumbent on the patient to ask those questions, just like you're saying, whether it's using your copay or just directly being your own advocate. I encourage everyone to be out there and asking the questions, because only by continuing to gather information and making it important to everyone, because when someone gets asked that information, then it becomes important to them because they need to go find that answer, right? So, but everyone needs to be their own best advocate.
Awesome. Well, this is a part where I ask you for your insights. If you were to say there's a book, a movie, a TV show that kind of really drives your point home about knowing the costs of healthcare, is there something that you would share with us? Yeah,
and I was thinking back onto a movie. It's not exceptionally recent, but it harkens back to where the government and the healthcare system was a bit behind the consumers in terms of finding the care that was needed and the pricing that was needed. And it's a little bit of an oddball choice for this, but I really think the Dallas Buyers Club is a good example where the FDA was directly fighting new treatments of HIV and AIDS, and entrepreneurial enterprising group circumvented that and or worked hard to try to get people the care that they needed.
Yeah, went down to Mexico
more
and
unconventional even than what we're trying to
no,
do.
I think that's I think that's a really great example because it's people caring for each other. That's what this whole conversation has been. Using their skills, right? You using your skills in analytics and physics and bringing all of that to be patient centered. And that movie is about that. It's about using your skills and finding family and caring for each other, which is what we have to do here in American healthcare. We have to turn around and figure out how to care for each other. I love that. That's a great one.
Oh, well, thank you.
Yeah, that was a good one. No, I was actually thinking about an older Denzel movie called John Q, where his child needed surgery and it was expensive. He ends up robbing a bank, right? Like does a stick up, and the whole thing is set.
Situation.
Right. The whole thing is set in this stick up. And I always thought it was weird that in the beginning of the movie, they had like a price tag. I don't remember the amount, but it was like, we need like $500,000. This is how much this is going to cost. But it was somebody who felt like they didn't have a choice, right? This care was no longer accessible. Things had gotten out of their price range and he was driven to desperation. And I think, unfortunately, that's a case a lot of people feel like they're desperate. And so maybe if we start with sharing the information about pricing, we can start being more equal participants in healthcare pricing. So this is awesome.
Exactly. We're all in this together because at one point or another, we're all patients, right?
Yes, it's very true. I call the hospital the DMV of healthcare. Like everyone's going to show up there at some point in time.
Right.
It's going to be crowded and they're not going to be excited to be there. But the goal is that we treat a lot better than the DMV.
I no doubt.
So, well, this has been another great episode of the Prescription for Admission podcast. I spent the conversation with Dr. Jason Lees talking about how we can improve information sharing, our healthcare pricing in hospitals. And this to me, has been a really, really helpful conversation. Thank you so much, Dr. Lees. And thank you so much to our listeners. As usual, if you're listening to us on Spotify, you can also find us anywhere else you listen to podcasts, such as Apple Podcasts. I'm also on YouTube. So go ahead, find us on YouTube for the Prescription for Admission podcast, and then hit that like and subscribe. And thank you so much. And come back for another episode. Bye now.